I'm going to talk to you about cemented dips. Where Hamburg is located. Hamburg is located in the northern part of Germany, about 300 kilometers from Berlin, our capital. Munich, where Bayern Munich yesterday won against Barcelona. Probably you have heard it 3-0. We are very proud that we have two teams in the Champions League final for Germany. But if you look at this slide, you can see it's a screenshot from the CNN television, which may have a big mistake. They put Switzerland right here, Switzerland, but in reality Switzerland is here. So this shows you that the Americans not always have a very good knowledge in the geographic situation. Another example, recently, right after the election of the Pope, they showed us this slide, you know? So don't believe the Americans every time. Our hospital, the ENDO clinic, is a very high specialized hospital where we are doing almost only joint replacements, about 6,500 a year, and you see we do a lot of primary hips and revision hips, more than 2,500 primaries and almost 1,300 revisions, and still 50%, almost 50% in the cemented way. So the question is always cemented or uncemented. From the literature, we know that both gives us very, very good results. The cemented on the one hand and also uncemented on the other hand. But there, since 20-25 years, there is a permanent struggle between the two groups, the cemented group and the uncemented group. But I like to make, this is more an emotional struggle. It's more a gut feeling, it's more a stomach feeling, and it has not really evidence. I'd like to show it and to make it more objective. If you're looking at on the revision burden of many countries, revision burden means how is the percentage of 100 joint replacement operations concerning the revisions. In Sweden, they have a revision burden of 8%. In the United States, for example, of 18%. Sweden is the last country where the majority of the surgeons are doing the cemented implants. And the US, as you all know, is the country where 90% of the surgeons are doing uncemented implants. If you divide it a little bit more, look a little bit deeper in it, you can see that the revision burden in Sweden for the cemented ones is just 7%, and for the cementless one, it's 18.6%. Let's go more in the details. Let's look at the cups. Why do I cement still my cups? Because we know from all the registries and the most literature, you know that the uncemented sockets have a higher dislocation rate. Why is that? Because the answer is easy. We all know if we put an uncemented cup in the acetabulum, we do not have really, if we are honest, 100% control about the positioning of our cup. If we do a cemented cup, we have enough time during the hardening of the cement to position the cup very well. This is a nice paper from Crawford where he compared almost 60,000 primary implants. He found an all-over revision rate of 0.7%, but almost 90% of the dislocations were with uncemented cups. Another very interesting navigation study from Australia showed the huge difference between the positioning of the uncemented and the cemented cups. More than 40% of the uncemented cups had a deviation of the version of more than 5 degrees and 0 of the cemented cups. And then they looked at the inclination uncemented cup were not inclined in the way that we want to have. The uncemented had a deviation of more than 5 degrees, whereas the cemented cups had 0. So if you look very, very clear in the literature, you will find very, very good results for the uncemented cups. But these results are just for the revision due to aseptic loosening. Very good long-term results, as you can see here, 10-year, 20 years results, 96% after 20 years, that by GEHRKE showed us 100% after 15 years. But if you go in deeper in the literature, you can see that the revision for all courses, and that is mostly the liner exchange rate, is not as good. And if we do a review about all the registries, we can see that some registries have really better results for the uncemented cups. But if you look deeper again, for all the revisions for all courses, then the cemented cups are always better in every registry. And you can also see that only the uncemented cups have a higher dislocation rate. Let's take a look at the stem. Why did I do the cement the stem? 4 reasons. Thigh pain, leg lengthening, intraoperative fracture, and late periprosthetic fracture. Thigh pain. As I told you, if you read the literature, fantastic long-term results for the uncemented stems. But, for example, the triangular, with a 10 to 12 years survival of 90.6%, has side pain up to 27%. And for the patient, not the rate of aseptic loosening is important. He has to feel very good, and if he has side pain, he doesn't feel very good. Leg length discrepancy. From the literature, we know that the uncemented stems produce significantly more leg length discrepancy than the uncemented stems. Ahmad showed it in a very nice paper that 56% of the uncemented stems had a leg length discrepancy of more than 1 centimeter, whereas only 23%, just 50% of them, had a leg length difference of more than 1 centimeter. He concluded the use of cemented femoral stems in total hip arthroplasty results in a lower incidence of leg length discrepancy. What about the intraoperative fractures? From the literature, we also know, this is a paper from Fernandez from Spain, perioperative fractures and uncemented limb replacements. He found an incidence of femoral fractures of 11%, which is really high. Some other studies showed this too. And we all know, especially from the registries, here from the Danish registry, for example, that intraoperative fractures increase the relative risk of revision during the first 6 postoperative months. So the outcome is really bad if you have intraoperative fracture. And what we know recently from the literature more and more is that the late reason for failure of uncemented stems is not the aseptic loosening, is more and more the late periprosthetic fracture. Strike could show us that the cumulative incidence of periprosthetic femoral fracture was just 1.6% after 10 years, but 4.5% after 17 years. And so we expect really more late periprosthetic fractures than aseptic loosenings in the future. What about the young patients? Is it allowed to operate young patients in a cemented way? From the registries, we know that we are operating, at least in Europe, more and more young patients. Data from the Swedish register showed us that even in the younger patients, even younger than 50 years, the cemented stems work better than the uncemented. Let's take a look to the UK, to the British, to the English and Wales registry. Also there, age below 55 years, the best results, better and if you're going older, age 55 and older, the cemented stems give us by far the best results. Very interesting series from Exeter, south of England. They looked after older patients under 50 years. They had a 100 stem survival at 17 years. In Norway, they found that the cemented cups work better, and the cemented stems, on the other hand, work better. If you're looking to the Australian registry, very interesting, 2010, data from 2010. Younger than 55 years, almost the same. And keep in your mind, Australia is a pure uncemented country. 90% are uncemented. Under 55 years, almost the same. 65 to 74 years, cementless works better. 65 to 74 years, cementless work better. And of course, old patients older than 75 years, cemented work better. This was 2010. If you are going into the registry in 2012, you can see very, very clearly that in all age groups, now the cemented work better than the uncemented. This is also shown by the Scandinavian registries and so on. Interesting study from Norway. They compared 3 groups, 15-year survival patients under 55 years. So one cementless group was a straight stem, cementless group was an anatomical stem, and the cemented group. After 15 years, they found a survival for the uncemented of about 60%, and for the cemented much better, 71%. But we are surgeons, and normally we are crazy, and we are not really working on an evident basis very much, including me. This shows very clearly the New Zealand registry. Only 10% in New Zealand are pure cemented implants. But if you look at the results, there you can see that the hybrid and uncemented stems work significantly better than the uncemented stems. And they wrote it down. They said uncemented arthroplasty has a statistically significantly higher revision rate in all except in this country under 55-year age band. But only 10% are cemented. 3 minutes more, and I'd like to show you a little bit about the principle and the technique of cementing. Cement needs cancellous bone. Our old hero, Surgeon Charlie, recognized in the 60s already that the surgeon who thought of cement as a glue is doomed to failure. Cement is not a glue. Cement needs penetration of the bone cement in the cancellous bone. Cement works like this. It must grip into the cancellous bone, and then you can fix the implant very well. So it doesn't make any sense to destruct all your cancellous bone with a rasp. You need the cancellous bone. Cement works like a tree doctor, a tree surgeon. If you have a sick tree with defects, then he stiffens, the tree surgeon, he stiffens the tree, the holes with cement. And this is the same what we are doing. But the most important thing, if you like to cement, you have to use modern cementing techniques. This shows you very nicely from the Swedish registry that as better your cementing technique is, as better your results are. What are the goals? First of all, we need a dry, bloodless surface. Second, we need, if it's possible, hypotension anesthesia, and we need pressurization in the cup and in the stem. Cementation, for example, should start from the bottle, and then you have to introduce the cement, and then you have to pressurize the cement into the cancellous bone. That's the only way. Here you can see in this very nice picture how the cement is going, penetrating in the cancellous bone. This is what we like to achieve. There are three parts in the modern cementing technique. First of all, proximal seal for pressurization. Second, pulsatile jet lavage. Third, distal cement plug. Pulsatile jet lavage, why do we use it? And why do we need it? Because we have to dry our cancellous bone bed, and we have to clean it. We have to wash out all the blood and the fat out of the cancellous bone. And if you compare jet lavage with manual syringe lavage, you can see in this very nice liver from Stephen Roy from Edinburgh how deep the cement is penetrating into the cancellous bone if you use jet lavage, if you compare it with the syringe lavage. Cementation of the femur should start always from the deep. What it should be done, it must be done in retrograde filling. But we need also pressurization. That's why we use a proximal seal. So to press the bone cement into the cancellous bone, like you can see here. This is a technique using a proximal seal to achieve a good pressurization. We all know that it has one disadvantage. The disadvantage is a slightly higher rate of thromboembolism. We know that during the cementation, the pressure, the peak pressure is very high, very, very high, much higher if you use the uncemented ones. But if you go into the literature, you can see that the uncemented stents, they don't have any risk of thromboembolism during the insertion of the stent. The cemented ones in the elective cases has 0.09%, that means 11 from 12,000 cases, and this is the only risk that I see. And a very good cemented implant should look like this, where you have a very deep penetration of the bone, of the cement into the bone. Thank you very much.
Bueno, a continuación tenemos otra excelente plática, la excelente ciudad del doctor GEHRKE.